Good afternoon, everyone. Thank you for joining us. Today, we are joined by Jonathan Pattenberg with Wintergreen. This is kind of wrapping up our week of swing bed discussion. And he will take more of a CEO, CFO financial approach, but we're talking about the post-acute care lever utilizing critical access hospital swing beds. As for the folks on the live call, we are a smaller group, so please feel free. If you have a question, feel free to blurt it out or put it in the chat. I'll be watching the chat. If you're watching the recording and you have a question or you'd like a follow-up to an item, please feel free to reach out to me and I can get in touch with Jonathan. So with that said, Jonathan, I'll turn it over to you.
Thanks, Laura. I'm excited to present on this topic today. Now, when we talk about swing beds, it's probably one of the most misunderstood programs out there in healthcare. I don't think we really could have picked a more unique name when exposing ourselves or discussing an actual post-acute care type service. Now, when we talk about the post-acute care lever, it's under the realization that this service provides a vital resource to most communities, particularly our critical access hospitals, to provide services to your patient population. Now, there's countless different ways that we can leverage this opportunity, everything from the type of services we offer, to the patients that we target, to the facilities that we coordinate and collaborate with around the providing of those services. Now, when we talk about the program itself, and we talk about all of these different opportunities, there's several different ways, again, that we can leverage this program. And we really have to start looking at how we can leverage the program as a means to improve both our financial, our operational, but also patient outcomes associated with each one of those individuals. Now, when we talk about in today's environment, all of us are experiencing an environment of increasing cost and either stagnant or minorly increasing reimbursements. And the swing bed program is also something that is not insulated from that environment. Many of us have had an increase in nursing cost or increase in supply cost, and all of these things are rolling through to us as critical access hospitals. Now, what makes it unique for us as critical access hospitals, particularly around the swing bed program, is the reimbursement methodology that is associated with that program. And for us as critical access hospitals from Medicare and in some states Medicaid, we get cost-based reimbursement for the providing of those post-acute care services in that swing bed program. Now, as we start to look at the nuances of the cost report itself and how all of those things play in, oftentimes a swing bed program under a critical access hospital is upwards of 90% cost-based because of the nuances of the cost report, and we'll talk through these later on. Now, when we look across the country, there are several organizations to truly leverage the swing bed program as itself. Now, when we talk about the swing bed program, we generally like to say organizations should be targeting a minimum average daily census of 4 per 10,000 people in your service area. And the math is pretty straightforward to that degree. If you have 10,000, you should be at 4. If you have 20,000, you should be at 8, and so forth. Now, this is used as a conceptual framework of how we should start to look at leveraging that program going forward. But depending upon the other services that we provide, we can oftentimes exceed that standard of that 4 per 10,000. Now, the last hospital I was a critical access, the last hospital I was a CFO at a critical access hospital, we went far beyond that 4 per 10,000. And we did it very much by implementing a strategic approach of working with the larger tertiary facilities where we would be more the providing of the post-acute care services. And unless they were your typical acute care type patients that we could care for in our facility, we were oftentimes transferring those patients to those larger facilities. So what we really looked at was ensuring that we could provide high quality services within the community and not get out beyond our skis when we were looking at providing those services to that patient population. Now, even though our community was in a community of about 20,000 people, we used to average about 14 swing bed patients at any one time. And again, it was through the building of relationships with those other entities and really going in a proactive approach at going after those patients as a means to pull patients back to our facility. Now, when we talk about an effective swing bed strategy, it really comes down to 3 fundamental areas: access, quality, and financial. Now, when we talk about the access, that's something that we can really start looking at within our organization. What services do we provide? Can we keep patients close to our facility? Do we have care coordination? Are we looking at all of those different things? Skipping over quality and going to financial, financial is probably the most attacked area relative to the swing bed program. I'm sure all of you have been on conversations with either an insurance company or somebody else that's talked about the cost per patient or the average daily cost for that patient. Again, many times in today's environments, we're seeing denials from insurance companies, or we're seeing patients being redirected to another facility because of the cost associated with care being provided in our facility. The last area, because critical access hospitals are broadly exempt from many of the public reporting requirements, quality has been something that's been very difficult to actually nail down for our swing bed programs. Oftentimes, we've known that the patients that are getting swing bed services at a critical access hospital are of higher quality than many of the other post acute care facilities. It was hard to actually define that and leverage that information because there was no way to compare that information or look at it across the broader country. Now, a few years ago, Ira Moskovitz actually came out and did a national study that looked at the outcomes associated with patients coming out of swing bed facilities and compared those to other post acute care type facilities and looked at the data that drove that. And what we saw is that patients that were receiving those services within that swing bed program at that critical access hospital oftentimes had improved outcomes that were higher and better than those received in those other post acute care settings. Now, what we have to do is to start to leverage this information and start to break down the story to really talk about the services that patients are receiving. We have to get away from talking about the daily rate of what it costs for a patient to receive services in a swing bed program. And we have to start talking about the total cost of care for the entire episode. Until we can start transitioning that conversation, particularly with the payers, we're going to continue to be in an uphill battle of having to discuss and combat those conversations around the daily cost of services within that swing bed program. So we have to start moving things forward and have to start breaking down that conversation. Now, when we talk about performance improvement and we talk about our swing bed program, I generally like to focus a little bit of time on performance improvement as a whole and really what we're looking at going forward. Now, when we talk about our swing bed program, when we talk about the value to the community, it's proven that our swing bed services are of high value and they really do lead to improved patient outcomes for our patient population. Again, when we look at a swing bed program, oftentimes the patients that are getting swing bed services have higher or better nurse to patient ratios. You're having more readily access to a provider, whether it's a physician or an APP. All of those things will help to improve the outcomes tied to our swing bed population. Now, when we step back and look at an overall performance improvement model, it very much, again, drives back to that value to the community. Now, when we break down that value to the community, it's really broken down across strategy and operations. Now, when we think about strategy, this is setting the broader goal for our organization. Now, within that strategy, we should be discussing the type of swing med patients we want to care for, the services we want to offer. Do we want to focus on certain things? Again, we as an organization, particularly as a critical access hospital, we cannot be a one size fits all approach, nor can we offer every single service that a patient may need around the swing bed program. So we have to be more strategic around the services that we're offering and the patients that we're caring for. Now, on the other side of the value to the community, it really gets down into the operations. And it really segments down even further into financial and quality. Now, when we talk about healthcare, it's one of the most segmented industries out there where finance is often doing finance stuff and quality is doing quality stuff. Now, when we relate this specifically to the swing bed program, I would say it even goes farther than that. Oftentimes, when we're talking about a swing bed program, CFOs and financial executives and different things to that degree are focused on the cost per unit of service and the daily routine rate and the step down of cost and all of those different factors. And when we think about the quality side, we're looking at improved patient outcomes. We're looking at, are they returning to the community? Do they have readmissions? And all of those different things to that degree. Now, what the swing bed program does, because of that cost-based reimbursement methodology, it insulates us from some of the conversations that we would have to have around a PPS methodology approach. Now, again, because upwards of 90% of our costs are reimbursed through that swing bed cost based methodology, it allows us to focus more on our quality improvement and more on our services offered to those patients as a means to drive that improvement going forward. Now, if we were a post acute care facility reimbursed under some type of alternative rate from a critical access hospital, it would put us in a different environment around some of those conversations. We would have to increase volume as a means to cover the cost associated with that program. But as a critical access hospital swing bed program, again, because we're getting a significant portion of the cost reimbursed through the cost report, it allows us to continue to push those services and target specific patient populations for the delivery of services. Now, when we talk about performance improvement opportunities, particularly with our swing bed program, we can really break it down into four main areas. We got operations, financial, value, and market. Now, as a critical access hospital, we have to ensure that we focus on each one of these different areas and leverage these opportunities as a means to increase performance and to drive patient outcomes. Now, we can't focus on any one of these specific areas at the expense of the other areas. Again, we can't look at cutting nursing back to a super low rate as a means to control costs, because then it's going to lessen the value, and in the end, it's going to hurt us operationally. Again, we can't hire a bunch of staff unnecessarily and maintain ratios of, say, 3 patients to every one nurse in a swing bed program, because that won't allow us to sustain ourselves financially. So it's a constant fine balancing act among those different four areas to really look at how we can drive those different opportunities going forward. Now, when we look at the different swing bed programs, I would say there are countless opportunities across the country and across each hospital to further leverage these opportunities within a critical access hospital swing bed program. Everything from payer contracting to rate negotiation to targeting niche markets to focusing on all these different areas, leveraging our swing bed NF rate. All of these are different opportunities as a way that not only we can differentiate ourselves from other providers of care, but also ways that we can improve our financial performance as an organization. And again, as we continue to improve our financial position as an organization, we can continue to reinvest in our facility and the services that we offer to our patient population. Now, when we talk about a critical access hospital, particularly our swing bed programs, I like to say that they could generally be one of the most expensive providers of care or the cheapest providers of care. It very much is dictated on our cost structure and the volume that we have within our facility tied to those services. Now, in today's environment, many of you are experiencing an environment where either insurance companies or system partners are trying to pull volume out of our facility and redirect them to cheaper or alternative places of care. Now, as a critical access hospital, because of our reimbursement structure, this only increases our average cost per unit of service and makes us as a more expensive provider of care. What we really have to start doing is engaging around the conversations of increasing volume at our facility so that we can drive down that cost per unit of service. As we continue to increase our volume at that facility, because most of our cost is fixed as a critical access hospital, we will start to drive down the cost per unit of service and will make us a cheaper provider of care than if we were to reduce volume, which would then make us a more expensive provider of care. Now, when we talk about the value of our swing bed program, value is ultimately determined by you looking at cost and quality. Now, cost is something that is easily discernible for our critical access hospitals. All of our cost reports are publicly available. Anybody can pull your cost report information. They can look at all of the data within your cost report and find out exactly what your cost structure is, what your routine rate is, and all of that other information. That's all publicly available information. On the other side of the coin is really the quality of services that we're providing. And this has really been a black hole for critical access hospitals across the country because we have not been able to really calculate and quantify the quality of services. And what this has been able to do is it's put us in a situation where organizations can question the cost structure but they have nothing to validate the quality of care within that swing bed program. In fact, if we go back to 2015, there was an OIG report that came out that really talked about the cost of care for the Medicare program. And what they talked about was if they switched critical access hospital reimbursement to the SNF PPS rates, Medicare would save over $4.1 billion over a 6-year period. Now, what this analysis didn't look at was it didn't look broadly at how critical access hospitals are reimbursed. It didn't look at your cost based reimbursement methodology, and it didn't look at all of those different factors. All it did was look at the average reimbursement rate that a critical access hospital receives and compared that to an average rate that the PPS rates were and said, this is how much we could save as a Medicare program if we were to change that reimbursement methodology. The concern is that if we were to change the reimbursement methodology for our critical access hospital swing bed programs, a significant portion of cost would just step down to other programs within that hospital. Med-surg would get more expensive for your acute care, the emergency department, lab, diagnostic imaging. All of these services would get more expensive now under that critical access hospital if they were to fundamentally change the reimbursement methodology for our critical access hospital swing bed programs. This is also something that, for those that are operating rural health clinics, have seen through the Consolidated Appropriations Act of 2021 by subjecting them to an upper payment limit. Again, all it's doing is forcing these organizations to operate in an environment where cost is continuing to increase at a greater rate than the reimbursements. And all it's going to do is bring to jeopardy the long-term position of either those services or those organizations by changing the fundamental methodology for reimbursement for those organizations. Again, we have to start getting into these conversations and have to start looking at quantifying the quality of care that we're providing within a swing bed program and using that as a means to justify the cost. Again, look at the total cost of care for the episode of a swing bed patient and compare that to the total cost of care for a patient that's receiving services in some other type of post-acute care setting. Now, when we talk about the quality position of our swing bed programs, again, swing beds in part are exempt from having to report most of the quality data that's required of other types of long-term care facilities, other types of SNFs, or things to that degree. Now, what this has done is it's put those critical access hospitals in a position where it's truly an uphill battle when comparing your organization to those other organizations. Other post-acute care facilities can refer to themselves as being a 5-star facility or being a provider of excellence or looking at all of those different factors. Critical access hospitals really have not had the ability to discuss or provide those type of conversations around the quality of care that they were receiving. Now, as I mentioned a few moments ago, Ira Moskovich in 2019, again, Ira has since retired, but Ira under the University of Minnesota did a comprehensive study that really wanted to look at assessing the quality of care received in that swing bed program. And really the goal was to finally have a conversation around, are the patients that are receiving services within that swing bed program of higher quality or lower quality to truly justify the cost of care within that swing bed program. Now, he looked at several different things. He looked at discharge disposition, 30-day follow-up status, and functional status. And again, the goal was to look at each of these different areas to identify for comparative purposes, was the patient better off or were they worse off? They look at transferred to long-term care facilities. Were they transferred to their home? Were they readmitted to the critical access hospital? Were they readmitted or sent to an emergency department? Again, all of these things were taken into account when they evaluated the information tied to those programs. Now, all of that analysis came out and actually showed that when they looked at risk-adjusted outcomes, the 30-day readmission rate for those patients that were in a critical access hospital and compared to the rural SNFs, only 13.6% of those patients were readmitted to a hospital post-discharge from that swing bed program. When they compared that to rural SNFs, 21.1% of those patients were admitted back to a PPS facility or a hospital facility post-discharge from that post-acute care setting. So this is a material difference that will impact the total cost of care for a patient outcome. And the impact was a roughly 7% differential between the differences in the patient that was getting the swing bed services versus the patient that was receiving care in another post acute care setting. Now, for patients that are readmitted and led to another DRG or some type of reimbursement for that larger hospital, again, this is something that comes at significant cost, whether it be Medicare, commercial payers, or so forth, relative to that patient outcome. Only 9.3% of those critical access hospital swing bed patients had an ED visit within 30 days of discharge. That information is not available for SNFs. 72% of the patients that were discharged from a swing bed program were discharged back to the community. Again, not discharged to a nursing home or some other type of facility to stay in that healthcare environment. These were patients that were truly discharged back to the community. So when we look at all of these scores and we look at these different factors, it shows that the quality of care being received by many of these patients within the swing bed program is in excess or better than much of the care that's received in many of these other post-acute care settings. Now, compounding this even further, because many of these swing bed programs are offering care to patients that either have multiple comorbidities or higher acuity level or different patient outcomes, oftentimes the ability to have comparable mobility scores or comparable self-care scores is something that should also be built up upon and discussed when we're talking about the swing bed services for these critical access hospitals. Again, if you have a patient that comes into your facility of a much higher acuity level or multiple comorbidities, the probability of them having a much better change in self-score or change in mobility is more difficult because the patients are more difficult to care for in that setting. So again, we have to start to leverage this quality information going forward. Now, when we look across the country and we look at all of these different factors, earlier I talked about targeting an average daily census of 4 per 10,000 people. Now, when we look at this 4 per 10,000 people, all of the dark blue boxes are those that are achieving that target, and all of the yellowish boxes are those that are not achieving the target. When we look broadly across the country, we can see there's a significant opportunity for organizations to achieve that 4 per 10,000 population. Even if we look across the state of Oklahoma, we do have several hospitals that are achieving that 4 per 10,000. We have several organizations that are not achieving that 4 per 10,000. Again, we have to look at our acute care census. We have to look at all of those different factors, and we have to blend the numbers to provide services to our patient population. However, if we are a 20 bed or a 25 bed critical access hospital, and we are not achieving that 4 per 10,000, and our average daily census is only a 4 or 5 or a 6, we do have the upside opportunity to increase volume within our facility to start to go forward and achieve that 4 per 10,000 patient population. Now, where does much of the conversation arrive around when we look at the cost of care and we talk about our critical access hospital swing bed program? Now, much of the conversation that we have to talk about when we're really looking at our critical access hospital swing bed program is the differentiation between fixed versus variable cost. Now, oftentimes we talk about the cost of care within our swing bed program. And granted, oftentimes these costs are significant and it is a costly service for the hospital. But when we talk about the program as a whole, we have to come to the realization that the fixed costs are things that we can really not change or effectuate change on a day-to-day basis. If we're operating as a critical access hospital swing bed program, it doesn't matter if we have 1 patient or 5 patients. Most likely we're going to have at least 1 nurse in that department. The same thing, it doesn't matter if we have 1 patient or 4 patients, we're most likely going to have a CNO that's also going, or CNA, sorry, that's also going to be providing services within that inpatient unit. The fixed costs are really those things that we can't change on a day-to-day basis. It's that unit staffing, our CFO salary, our CEO salary, the cost of the facility, General Electric, all of those day-to-day operating costs that are going to exist whether we have 1 patient or no patient, or 1,000 patients or no patient. Our variable costs are those costs that can truly be changed on a day-to-day basis. It's the incremental medical supplies, pharmaceutical costs for our patients, if we have to flex staffing and increase staffing because we've surpassed our nurse to patient ratios, all of that is that variable cost. Now, when we talk about the distribution of variable cost versus fixed cost within our organization, upwards of 90% of our cost as a critical access hospital is fixed. And we can really only change roughly 10% of that cost as we continue to provide more services to a greater patient population. Now, taking that into account, when we look at the distribution of fixed cost versus variable cost, this is how or what dictates the fact that we could be one of the cheapest providers of care or the most expensive providers of care as a critical access hospital. As we continue right, and as we see our fixed costs remain stagnant and that variable costs go up, our variable cost does not increase as much as proportionally relative to that volume increase. So as we're able to increase volume going forward, we're only going to have minor increases in that variable cost, and that fixed cost is going to continue to dilute down and be spread across a greater number of services within our hospital. Now, when we talk about a critical access hospital also, because we receive cost-based reimbursement from Medicare and many states Medicaid, the only true way that we can make a profit as a critical access hospital, again, carving out 340B, maybe mill rates or tax subsidies, all of that other incremental non-operating revenue type things, when we provide services as a critical access hospital, the only true way that we can make a profit as a critical access hospital is to drive down our cost per unit of service to less than what we're receiving from a commercial payer or workers' comp, our non-Medicare, non-cost based business. So long as our cost per unit of service that we're getting, and let's say our cost per rate is $1,000 per day for a acute care patient, if we're only receiving $500 a day for a commercial patient, we're having to make up that $500 a day through other type of revenue opportunities. If we're able to drive down that cost per unit of service to where our daily cost per unit of service is less than what we're receiving from commercial, now we're actually going to start making a profit for that service. So again, this is how we have to start looking at ourselves as a critical access hospital, and particularly those that are operating swing bed type services. Now, to take this a step further, when we talk about our swing bed program, what makes this unique as a critical access hospital is how Medicare will actually calculate and determine the impact of non-Medicare business on our cost report. So all of us, if you could take one thing away from today's presentation, it's really to master and look at what is our Medicaid NF swing bed rate and how can we leverage this rate to start negotiating with commercial and non-Medicare payers because of how it impacts our cost report. So as an example, let's say we started with a daily cost-based rate of $1,000. That's our Medicare routine cost-based rate is $1,000. For every Medicare patient we take, Medicare is going to give us that $1,000. Medicare Advantage should also be giving us that $1,000. Now, here's where the misconception comes in for many critical access hospitals, particularly when the conversations are going between the finance side and the clinical side. Oftentimes, organizations will talk about that cost of care, and the nursing staff believes that if they're not able to get that $1,000 daily rate for a commercial or non-Medicare patient, that they shouldn't take that patient. And this is not how it works on the critical access hospital's cost report. Critical access hospital, all of the patient days that are non-Medicare and non-Medicare Advantage get carved out at that daily NF rate. So what I mean by this is, as an organization, you have your daily fully allocated cost for your organization for that year. And let's say the fully allocated cost for your organization is $3 million for your med-surg department. What ends up happening as an organization is they will take your daily NF rate times the number of non-Medicare Advantage days, and they will subtract that from that fully allocated cost, and then they will then use that figure divided by the days that you have, not including those non-Medicare days, to determine that daily routine rate. So how this can be leveraged as a strategy for your organization is to take that number and use that as a way that you can negotiate with commercial payers. So let's say that our daily carve-out rate is $250. If we're able to negotiate a $500 daily rate with a commercial payer and our carve out cost report impact is only $250, we are going to make $250 profit relative to that cost report impact. So I'll give you an example. This was a hospital in New York that ended up negotiating a $1,000 daily rate with a commercial payer to do certain type of rehab services. Now, their daily NF carve out rate was only around that $250. So this organization was able to make $750 profit relative to the cost report impact of that $250 rate. It changed the dynamic where this organization was going out and now starting to target certain patients or target certain services because of that NF carve out rate. Other organizations have also used this as a means to negotiate with their sister entities or other larger hospitals, where that larger hospital is paying them a rate in excess of that NF rate so that they can free up beds at their facility to take other DRG type inpatients. So, again, leverage this as a marketing ploy and as a strategic differentiation as to how you can start to target patients that are non-Medicare, non-Medicare Advantage, and not have it materially or negatively impact your organization because of how the cost report works. Now, next up on the screen is an example of how this ends up working. Now, up on the screen, we have an organization that had an average daily census across all services of about 11.9. Now, this contribution margin or the net margin for this program was about a negative $460,000. And again, that's because of the differential between what they're getting on the acute care side for those services and observation and so forth. Now, the cost per day, the average routine cost was roughly $1,800 per day for this critical access hospital. Now, if this organization were able to increase the average daily census by 2, going from 3.2 to 5.2, and again, this is easily achievable for organizations. I'm not saying to increase it by 7 or 10 or double your volume. If this organization was able to increase their swing bed volume by 2, it would have improved their net position by $258,000 a year. So nearly $250,000 in improvement by increasing their swing bed volume by 2. And the reason for this is because they would have diluted down the average cost per day, that routine rate, from $1,800 a day to less than $1,600 a day. This would cause a material increase in their position. Now, taking this a step further, as a part of the analysis for this hospital, we only increased the swing bed SNF side, the Medicare days. If we had looked at increasing the swing bed NF side, and again, looked at increasing that cost report carve out, it would have improved their position even further if they were able to get the rate in excess of what that cost report rate was. So again, this is an opportunity we have to start looking at, and we have to leverage that swing bed program strategically as a means to drive performance going forward. Now, one of the next areas that we can look at, and this is starting to get into the differentiation of our services compared to other organizations. Now, what we really have to start looking at, particularly as critical access hospitals, how we can differentiate the services that we provide in a post-acute care setting from the services that other facilities are providing. Now, when we talk about our swing bed program, all hospitals can do our basic IV antibiotics. They can all do the physical therapy. They can all do those core services. However, there are countless other services that we can provide within a swing bed program that would allow us to differentiate ourselves from other providers. For instance, not all facilities can handle patients that need trachs. Not all facilities can handle bariatric patients. Not all facilities can do wound care because maybe they can't do the debridement or they don't have wound vacs or whatever the case may be. As we start to evaluate our services, we have to evaluate the services that we can provide within that swing bed program as a means of a strategic differentiator of how we can start reaching out to larger facilities for the providing of those services. Now, up on the screen is wound care. Now, when we talk about wound care services, we want to go through and evaluate the staff that we have, the competencies, the equipment, the ability to provide those services. All of those different factors we want to take into account when we're evaluating, can we provide wound care services? It's something that we want to use as a strategic differentiation. Now, in addition to using that as a way that we could differentiate our services versus other services, what we also want to use this as a means to identify gaps and barriers for providing these services going forward. For instance, say we go through and evaluate all of the services that we can provide, and the only thing that is preventing us from taking a wound care patient is we don't have a wound vac. This now breaks down some of the barriers and allows our CFO and our CNO to work together to discuss equipment purchases or staff training or competencies or different things as a means to continue to drive and expand the services that we can provide going forward. So, again, use the scope of care to evaluate what you can provide now, but also use the scope of care to identify the gaps and the barriers that are preventing you from identifying additional services or providing those additional services. Now, when we talk about that critical access hospital, also because they have better nurse to patient ratios and you have physical therapy on site and you have providers on site regularly, again, we can target more difficult to care for patients as a means to start to drive some of those conversations and to drive patients within our facility. Now, the next couple areas that I'm going to talk about are probably two of the biggest opportunities for critical access hospitals. And frankly, they're the two biggest barriers preventing you from getting patients within your facility when compared to other post acute care settings. And the first one is really around the active pursuit of patients. Now, when we talk about the active pursuit of patients, when we compare swing bed services to other services within a hospital, patients that need emergency services come to your emergency room. Patients that need lab work, x-rays, and so forth, they all come to your facility. They know your facility provides those services. When we're talking about post-acute care services, these patients are already in a care setting. So we're not always actively going after the patient. We're also having to market ourselves to the larger facilities, the care planners, the discharge planners, caseworkers, all of those individuals around getting patients to our facility. Now, as we have those conversations and as we're looking at getting those patients to our facility, it really evolves an active pursuit of those patients. Now, what I mean by active pursuit is it's the process of actively going after and engaging those larger hospitals on a day-to-day basis around patients that could be potentially put into your facility. Now, when we talk about the active pursuit and we compare swing bed programs under critical access hospitals to other post-acute care settings, other post-acute care type facilities can make a decision, yes or no, whether to accept the patient in less than 2 hours. The average for a critical access hospital to make a yes or no decision ranges anywhere from a couple hours to a couple days. Now, the problem with this is if you're taking a couple hours or a couple days to make a decision, all of those easy to care patients are already going to be placed in other facilities. Again, because the goal of those discharge planners at those larger facilities is to get patients out of their beds in other alternative care settings based on the needs of that patient at any one time. So again, if we have a patient that just needs a couple weeks of rehab, that has 100 days of Medicare eligibility, no comorbidities, no other issues, those patients are going to be quick to place and they're going to be out the door very fast. If we're waiting those couple days, by the time we reach back out to that facility about that Medicare patient that has, that physical therapy need, we're going to be referred patients that can't get placed in other facilities. We also have to realize that us as critical access hospitals, because we're limited in the number of beds that we have, we are not going to be the first facility that all of these larger organizations are going to call. They're going to call that 100-bed SNF or that 100-bed rehab facility or those other facilities that could potentially take 10 or 20 patients a day. As a 25-bed critical access hospital, we're most likely limited in the number of patients we could take at any one time. So we have to be very much more proactive in going after patients and trying to get patients sent to our facility. On top of that, those other SNFs, those other post-acute care facilities, oftentimes they will have an individual placed at those larger facilities to help facilitate and transition the care of patients to their facility. We have to start making or taking a proactive role in going after patients and trying to pursue patients to that means. The next area is really around the admission process. Now, a moment ago, we talked about active pursuit and how we have to start going after patients. And it really doesn't matter whether or not we get access to their EHR to a curated list, or we look at all of those different factors, or we're calling on a day to day basis. The goal is that we have to take that active approach in going after patients. The thing that really slows us down at critical access hospitals is the admission process itself. And this is something the last hospital I was working at that we really took a proactive role, not only in the active pursuit, but also streamlining the admissions process. And again, the goal was to take the least amount of time possible to try to get a patient into our facility. Now, when we looked at the admission process, again, you can make minor tweaks to the process itself, but it should generally follow a consistent approach. You're ultimately starting at a pending discharge review all the way through to the end of patient pursuit. Now, physician review or APP review should always be near the end of the process. But the things in between, the pharmacy review, business office review, rehab review, those we can fluctuate based on the specific needs and the specific flow of information within our organization. Now, what our organization did is we realized that every single day, the discharge planner came into that larger hospital at 8 a.m. So what we did is we started the process every morning at 6 a.m., 6:30, so that every day, by the time that case manager came into that larger facility at 8 a.m., we were reaching out to them saying, we can take X number of patients today and let's start the process. We were not waiting for that case manager to call us at 2 o'clock in the afternoon or fax us some information at 2 o'clock in the afternoon to start that process. We were very much proactive in that process. Now, when we start with the pending discharge review, again, what we want to evaluate every single day is the number of beds we have available within our facility. We want to constantly keep a list of the patients there, when the patients are going to be discharged from our facility, or an estimate of when they're going to be discharged, and really looking at how many beds we have available per day. So let's say we have 5 beds available today. What we want to do is log into their EHR. We want to pull information. We want to get information to try to fill those 5 beds that day. So maybe we're going to pull down 10 patient records to start this process. Now, the first person we would go to is we'd go to the pharmacist. We'd have a look through to see if we can get the medications, were there any issues and all that. So maybe out of those 10 patients, the pharmacist would say, okay, we can't get this medication. We can't meet the needs of that patient. So now we're down to a list of 9 patients that we then, again, evaluate each one of those patients and go on to the next process. Then we'd go to the business office review. Could we get prior authorizations? Did they have days of eligibility? We log into DDEA for Medicare. We check all of these different things and look at, were we able to provide care, and did they have the insurance and so forth to receive care within our facility? Next, we would go to medical equipment review. Again, do we have enough IV pumps? Do we have bariatric beds? Do we have Hoyer lifts? Do we have wound vacs? Again, we would look at the care requirements for each patient and evaluate whether or not we had the medical equipment to provide services to that patient within our facility. Next, we'd go to rehab. And again, we'd have our rehab department evaluate. Did they meet the skill requirements? Did they meet the need? Was it medically necessity that they would get those services within a critical access hospital post-acute care setting? Again, maybe now we're down to a list of 6 people based on the prior review of all of those different areas. The last person that we'd go to was the provider and say, these 6 patients have been reviewed by all of the other departments. They meet the needs, they meet the services. Do you want to pursue admitting these patients into our facility? The reason why we would do the provider last is because the provider is one of the most costly individuals that you have in your facility. If we could exclude a patient from receiving services at our facility because they didn't meet the rehab requirement, or we couldn't get the medications, why would we have our provider review those patient records if they were excluded elsewhere? So now we would then identify, the provider would say, yes, start the process to admit these patients into our facility. We would then go into the patient pursuit area where we would reach out to that facility and start to further solidify getting patients to our facility. Again, with the patient choice in mind, getting a full comprehensive medical record so we could do a comprehensive review of all the information. And again, looking at all of those different factors. Now, in addition to that, after we would get those patients, we also use this patient admission process to help drive additional efforts going forward. We would then look at all of the patients that we denied receiving care at our facility or did not pursue, whether it's because of clinical competencies or medical equipment or pharmaceuticals or whatever the case may be. We would use that as a means to start to drive performance improvement and ways that we can continue to expand our services down the road. Again, constantly learning and constantly evaluating the services to that degree. Now, the last area we're going to focus on is really around the quantification of quality within our program. Now, in today's times, there's additional opportunities for us as critical access hospitals to really certify our swing bed program as being of high quality around the care that we're providing. Now, I know the compliance team is an entity that offers this. And what we want to look at is, again, all through all means as a way to differentiate ourselves from other facilities. Because the environment is not going to change where insurance companies and other hospitals, particularly those that are in ACOs and at risk, are going to want to validate the quality of services, we have to continue to look at additional opportunities to quantify ourselves the quality of care that we're providing within our facilities. Only then can we truly start to compare ourselves to other post-acute care type facilities of establishing ourselves as a high quality provider that even though the daily cost of care may be higher than other facilities, when we start looking at the total episodic level of care and the total cost of care for that entire episode is truly better than what many patients receive in other post-acute care type settings. So I know I've gone through a lot of information very quickly. Again, my goal is always to share as much information as possible to really start to expand and open our eyes to different opportunities and different things that we need to think about as care providers. Now, again, as I mentioned earlier, if we want to look at those significant opportunities within our facility, we really want to start looking at how can we leverage that swing bed NF rate as a way to drive performance improvement and increased reimbursement to our facility. We also want to start looking at creating niche markets. We have to find ways to differentiate ourselves from other facilities and really establish ourselves as centers of excellence in an area that we can do better than other facilities. Only then can we start to increase reliance on our facility. Only then can we start to increase outcomes for our facility for this swing bed program. So now I'm going to pause for a moment. And again, I want to open this up to, are there any questions that I can answer around this topic or swing bed programs in general as we're available today?
I have a question.
Yes.
Yeah, just curious about, a lot of programs only have physical therapy, and I'm just curious about the addition of occupational therapy services. I know it probably depends on your payer mix at the facility, but just curious about the impact on the overall cost versus revenue. What your opinion might be on that?
Yeah, anytime you can look at adding those other ancillary services, we obviously want to do some type of contribution margin analysis. But there are critical access hospitals across the country that are very successful and have fully integrated occupational therapy in conjunction with physical therapy. Some also do respiratory therapy type stuff. So there is the ability to integrate those additional rehab services. What I would say though is when we're looking at those services, if the only service that we provide is those services to a swing bed patient, it may be difficult to justify the ROI for those specific services. So I would look at complementing that or supplementing that with also providing additional occupational services to the broader community in an outpatient setting. But there is the ability to integrate those services into the overall care plan for a patient that's getting swing bed services.
Thank you very much.
And then again, any of those occupational services that you would provide to those swing bed patients would also step down on the same methodology through your cost report on the D3 for the applicable charges, where you would then get that added back in as an ancillary service.
Got it. Thank you.
Any other questions? Again, we could submit them in the chat box or please feel free to unmute yourself. All right, so not seeing any other questions come in, I'm going to turn it back over to Laura, who's going to do some closing remarks.
Thank you. Yes, I was just checking. Our next scheduled webinar is in 3 weeks. It's March 30th. And the topic for that day is understanding your options, primary care designations, and strategies. I will be sending out after this call, once we get this uploaded to YouTube, I'll send out the link along with the slides, as well as a reminder in the registration link for the upcoming webinars. If you have any questions at all, if you're watching the recording and you have questions, please reach out to us. We want to be here to help. And thank you all for your time. And thank you, Jonathan.